very well-known expert in cutaneous lymphoma. He come from Arkansas, where he was chairman, and before that, a long list of other places, very great, where he also trained as an immunodermatologist. Dr. Harry?
Great. Thank you very much, Adina. It's a real pleasure to be here. Happy to join the VA and join the community and be part of the group that I think is very vibrant. And I think, Dr. Gallo has facilitated it, and this is a great opportunity for me. So thank you. Great to meet all of you. I'm going to talk about some, CTCL. With academic dermatology, you're able to focus on an area and really learn a lot about it and gain insight and learn about dermatology. In the old days, it was dermatology and syphilis. In my mind, is dermatology and my CTCL. And I think I can learn a lot about dermatology from CTCL. So this will be the organization of the presentation. I'll provide some overview just to put it into perspective. Then I'll talk about our translational research, focus on gene expression abnormalities, and then that led us to identification of epigenetic abnormalities as a potential driver of the disease. And then we'll use the gene expression abnormalities to really to help diagnose, and then also as a way to follow monitor disease. So how do I think about CTCL? Well, CTCL is a large group of lymphomas, but mycosis fungoides and Sézary syndrome is really a more indolent group. And I think of mycosis fungoides and Sézary syndrome as having two personalities. I don't know if everyone's heard about Dr. Jekyll and Mr. Hyde. It's a little bit old, but for some of us, who are older, remember about it. And so CTCL has two personalities. There's a good side, Dr. Jekyll, and then the other side is Mr. Hyde, who's aggressive and bad, and that's the disease that we don't want. So our goal is to find treatment for Mr. Hyde and to stay more indolent. So let's go back in terms of the earliest description. This was first presented by Dr. Jean Alibert from Paris over 200 years ago. He described a person, his name's Lucas, and you can see the picture here. And he had scaly eruptions that grew to the typical lesions that we see, that leads to the name mycosis fungoides or mycotic-like. It progressed over many years. So in this patient, it had an indolent phase as well. And then this patient died of a hectic fever, and that was the description. And what that means is, these patients in the advanced phase probably die of immunosuppression or infection. And that's really the cause today from burden of the disease. This condition was recognized by other dermatologists over the years. Bazin, I think, showed that, more characterized the natural progression, confirmed that pre-mycotic phase to plaques to tumors. Now, we also, I talk about Sézary syndrome, mycosis fungoides and Sézary syndrome, and 100 years later, Sézary and Bouvrin reported a patient, a 59-year-old woman who had exfoliative erythroderma, enlarged lymph node, and leukemic with monster cells in the blood. And the histology, at that time, they saw it showed intraepidermal abscesses, similar to MF. And so that linked the two diseases together, and they called it paramycosis hematroph. And so there's a relationship between these two. And then this is reaffirmed more firmly in the 60s at the NIH. Clennington, Belcher, and Van Scott looked at a series of 33 cases of MF and asked, do we see similarities among these types of patients, MF and Sézary? And what they found was that 20% of MF patients show abnormal cells in the blood. And then in skin and Sézary patients show epidermal microabscesses. And then, of course, now you know about the typical abnormal lymphocytes, enlarged nuclei with cleaved nuclei. So it shows that these two have high similarities, at least we're part of a spectrum. And then later on in the 70s, as we developed more advances in immunology, the immune classification helped improve classification of lymphomas, and then led to more precision of the cell types that are MF and Sézary syndrome. So surface markers classify MF and Sézary syndrome to be CD4 positive most commonly. And also they express the marker CD45RO, which is associated with memory marker. And then more recently, we find that CD7 is a marker that's lost in MF and Sézary. So that's improved the classification, and we have a picture of what MF and Sézary is like, and the relationship between the two. I think we need to delve more into it, and that will help us treat patients better. Now, in terms of skin lymphoma, from a dermatology perspective, MF and Sézary are really considered orphan diseases. They're fairly rare. So how does that relate to other lymphomas, across the incidence each year? Each year, there are about 80,000 new cases of lymphoma, okay? Now, this shows the distributions. Most lymphomas are actually B-cell lymphomas, so hematologists, oncologists really think more about B-cell subsets, and there's the subset of T cells are less frequent, more rare, so, and actually these are more aggressive. And there's been, and because it's been more rare, less studies have been able to be performed to really characterize it better. But we're making a lot of progress more recently. But because of that, there has not been a lot of great treatments for T-cell lymphomas in general. But how about skin lymphomas in general? Well, skin lymphomas are a small subset of lymphomas. They're less common, but dermatologists are pretty aware of it. And there's been a lot of training over the past years, and the recognition by dermatologists is excellent. In the skin, we think of, when we think of lymphomas, most people think of T-cell lymphoma, and that's actually the subset that's more common in the skin compared to, systemic lymphomas. It's a B-cell lymphomas that are more common, and B-cell lymphomas are about 30%. Now, T-cell lymphomas, have been better classified. I just want to review the classification just to put this into perspective. It's been divided into skin, extranodal, nodal, and leukemic. And in general, most T-cell lymphomas are highly aggressive, and that's shown by the orange. But skin lymphoma is more indolent compared to the systemic counterpart. And so our perspective will be different. And the importance is that we don't want to classify it as an aggressive lymphoma and treat it as such. And so that's one of the aspects that as a dermatologist, we want to make sure it gets to the right team so that we don't get patients treated overly aggressively. Now, MF, I'm going to speak mostly about MF and Sézary syndrome today, and that constitute 55% of the cutaneous lymphomas, and we have the other subsets. And in general, these are more indolent again. Occasionally, there are a few skin lymphomas that can be very aggressive, and that could be the gamma delta T cells, and those are where there's less treatment. So what's the incidence of skin lymphoma over the past 20 years compared to what has been published by Weinstock many years ago? The incidence has gone up slowly. Today, most recently, between 2000 and 2017, the incidence is greater. Previously, it was like 0.9 per 100,000 per year. Now it's 1.4 per 100,000 per year. It's greater, more frequent in men than women. And then in terms of demographic distribution, here, there's been many reports that it's been increased in African Americans, and we do see that it's slightly higher than the Caucasians and compared to other demographics. And also, from my experience in seeing patients in different regions, patients, African Americans have more aggressive disease, and so it presents a little bit earlier, and it's important to be aware of that so that we can treat the patients properly. This shows the CTCL incidence across the world from Dobos, and he reviewed a number of publications to get demographics, and it's pretty stable, about 65 to 70% in terms are mycosis fungoides and Sézary syndrome. So it's that's a distribution across the world. Now, so diagnosis and staging of mycosis fungoides and Sézary syndrome. This is, the diagnosis is based on history, physical, and then histology, laboratory, and imaging. And I won't go into the details, but of the diagnosis, but diagnosis is to determine the extent of skin burden, and that will be important in treating patients, directing treatment. So, the staging is from stage 1 to stage 4. Early stage have a general excellent prognosis. In terms of staging, stage 1A to 2A, I classify as early stage. They have limited skin involvement. The burden of disease is not high. Stage 2B is associated with tumors, and that's when the burden of disease increases. And so at that point, I think the progression changes, and beyond stage 2B, survival is affected. And that's shown by the Kaplan-Meier study here. And this was published many years ago, but this has been repeated in a number of studies over the years. So if we look at survival of stage 1, stage 1B, and 2A, it's distinct from the subset that are stage 2B and beyond. And so there's a cutoff here. There's a gap here. And so beyond stage 2B, patients need to be monitor to make sure they don't progress or try to control the disease and use more systemic treatment. This is the subset that I would consider maybe the Mr. Hyde subset, and we need to learn more about it and understand why it progresses this way. Now, what are variables that have been associated with survival for patients with MF and Sézary syndrome? A paper published by Skarisberg international study showed that these are the variables that are most important in survival: age, the type of MF, follicular tropism, increased LDH, large cell transformation. And then these other variables have not been shown to be associated with affecting survival. Now, in terms of this disease, MF and Sézary syndrome, there are challenges in diagnosis, and I think it persists to today. That's because it's clinically very heterogeneous. Lesions can be atypical. There's non-specific morphology. There are different subtypes. There's variability in pathology. And then it can be difficult to differentiate erythrodermic skin disease from evolving skin lymphoma. And so, so that's driven our work or my focus. Additional markers remain needed to really, better treat this subset of patients, treat them appropriately. Now, this shows manifestation of cutaneous inflammation, right? I mean, skin inflammation can have a lot of overlap. I mean, I'm not going to have the residents go through differential, but you might figure out some of them. But it can be very confusing at times, I think, especially from primary care doctors. They'll send patients and say, what does this patient have? And sometimes it can be challenging to differentiate rheumatic disease from even erythrodermic or evolving skin lymphoma. And in terms of why that may be the case, here's what happens in the skin, the types of cells that lead to skin disease. In terms of skin lymphoma, MF and SS, these originate from naive T cells that differentiate into more memory effective T cells. There are different types. I mean, that's been defined more specifically into two subsets, and they may lead to contributing to the distinct subsets of lymphoma that we see, maybe Sézary syndrome, mycosis fungoides. Now, but recently we also have resident memory T cells that are part of the skin, and they contribute to skin disease. Now, what we know is that immune cells in the skin can cause a lot of different skin diseases, and our goal is to make sure we identify the right type of cells, whether it's neoplastic or inflammatory, that actually causes the disease, because because that's important in really treating the patients appropriately. I mean, we've had significant progress in understanding inflammatory skin disease with a lot of new treatments, and more will come. And I think so. It's important that we don't treat inflammatory diseases with skin lymphoma drug or vice versa. And even T cells that are part of PTCL, peripheral T cell lymphoma, these are mature T cells. They can cause paraneoplastic inflammation that can be confounding and confusing. So it's important to have precision in markers that can help differentiate. So here's an example. I mean, this happens. I mean, it happens now, and with particularly with the new drugs that we have, dupilumab. It's a great drug. I mean, we talked about it this morning. It treats atopic. It's been transforming for a lot of patients. But we can't treat every itchy patient with it. Here's a case report where dupilumab unmasked Sézary syndrome. And this, you can see the abnormal cells. I mean, I'm sure that early on, it wasn't really clear. But dupilumab helped unmask that. And here's another case where mycosis fungoides was, unmasked following treatment of atopic dermatitis. So it's important to know what we're treating, have better markers to know really where these dermatitis, where they're borderline, where the clinical presentation is not absolutely clear. And how do I, so this is just an illustration of how, the treatment algorithm, you want to be able to separate benign diseases. We have Th1, Th2. I mean, connective tissue would probably, we can include that. I didn't include that, but lupus or dermatomyositis, from T-cell diseases, neoplastic T-cell diseases. And we want to make sure we treat patients with the appropriate medicines, right? So with benign inflammatory diseases, you want to use immunosuppressants or differentiating drugs. You don't want to use, for example, Dupixent, because that's not appropriate for CTCL or other lymphomas that have itchiness. And then in the literature historically, a lot of and colleagues have used cyclosporin to treat itchy disease. Well, that also unmasks CTCL. On the other hand, we can't assume everyone has CTCL, or I can't, and I don't want to treat everyone with cytotoxic drugs. It wouldn't be right for those patients. So we really need to improve markers to really classify patients more appropriately. So that leads to really the strategy that I've taken to really better understand CTCL, mycosis fungoides, and Sézary syndrome. And at least with MF and Sézary syndrome, patients at Sézary syndromes have a lot of abnormal cells in the blood, and that's one way to get a uniform population, really to understand genetic and molecular abnormalities. I mean, we didn't have some of the refining single cell studies, single cell techniques that we have now. But I think, but studying a monomorphous population can give you a lot more insight into disease. So one of the first things that we did do is we had identified, looking at just normal T cells, that CTLA4 is a marker that's higher in the CD45-RO subset. And we found that from a differential screen. And I just want to show you what happens and how they differentiate. So a normal naive cell don't express CTLA4. This is a flow cytometry of a T cell marker to CTLA4. And you have to activate normal T cells. And naive T cells do not upregulate upregulate CTLA4 like memory T cells. And you can see that it's very different. And that makes sense, right? Memory T cells will upregulate genes important immune functions better. And now we know that CTLA4 probably is inhibitory. And so it's to prevent the memory reaction from becoming overly robust. Well, what about Sézary T cells? If we stimulate Sézary T cells, we see that this subset has significant expression of CTLA4 and much higher than memory T cells. So from that, we concluded that at least Sézary or T cells retain some of the memory functions. But is that actually the case? So then memory T cells also, would express higher levels of cytokines. They're ready to regulate the immune response. So once they're mature, they express high levels of whatever types of T cells they have. Well, here's an example. We looked at cytokine gene expression. And so what we found was that, yes, although sensory T cells express CD45RO, they don't express cytokines like memory T cells. So here's a naive T cell, and here's a memory T cells really upregulate interferon very robustly. But if you stimulate sensory T cells, they don't behave like that. And they're just not very responsive at all. And so that suggests that their functional status is not normal. And we sort of know that, but at least it shows that we can measure that. So that led to us asking, well, how abnormal are sensory T cells compared to normal memory T cells? We purified normal memory T cells and then purified sensory T cells. We then looked at the gene profile on Affymetric microarray chips. And in this experiment, we stimulate the patient's T cells with 4-ball esters to upregulate the cytokines and look at functional difference. And we can see that there are 533 significant genes that are highly differentially expressed. And that's just, and the heat map is shown on the left. So you can see that there's differences in gene expression between normal and the sensory cells. And unstimulated, as you would expect, there's, the top part of this panel is cytokines, is blue, but then once you stimulate, normal cells upregulate cytokines robustly. Sensory cells, consistent with what we saw earlier, the cytokine genes aren't expressed significantly at all. But then we also looked at, what other genes are differentially expressed. And here you can see we have a population of genes that are not expressed in normal, but highly expressed in the sensory T cells. So what are these genes? So we found that these are some abnormal genes, genes that really I never heard of prior, but they're actin binding proteins. Some of these are transcription factors, chemokine, but then other structural proteins. One of the genes that we found was TOX, that now we know has some function in immune regulation. And then also consistently, we do see GATA3, which is consistent with what we would expect in the sensory cells. They're more Th2. So what are these genes, and can we get a picture of what kind of genes these are? And we look at gene ontology, and what this says is we plug in a list, and it shows that these genes enrich for function for neurogenesis, and these are not generally T cell genes. And we found that these are not, most of these genes are not expressed in the peripheral blood at all. And this just shows the genes that we identified that are part of, that can be classified in the neurogenesis subset. Now, one of the genes that I mentioned we found increased was TOX, and that was identified in sensory cells. So is TOX seen in mycosis fungoides? And what we, and this was a study done by, Laura McGurk, and she showed that, yes, TOX is actually detected in MF, and this is in an advanced tumor. So you can see the staining here. And when we looked at expression in MF, so we look at the level of TOX gene expression by RT-PCR in it. And we were actually we just look at the peripheral blood. We reason that if these markers are really highly expressed, we should be able to detect it in the peripheral blood. And so this is just the peripheral blood from Sézary syndrome. And we do see a slight increase in the expression of the tox gene expression from stage 1 to stage 4. So these genes can be detected in MF. Well, what about some of the other genes? So we then went and looked at some of the other genes that we did identify, and we asked, can we detect these in the peripheral blood in MF? And what we did here was we looked at genes that we classified genes into very high expressed, because we didn't want to group them together, because then otherwise it would just drown out the genes that were low in expression. And we can see a high expression subset is very specific for Sézary, but it's not really expressed highly in MF. And these are genes that, if we just look at the fold change, this PLS3 plasmin, it's expressed up to 1,000 times higher than in normal peripheral blood. Now we have other genes, TWIST, DNM3. We do see expression higher in more advanced MF, those with tumors, MF stage 4. And then we have a subset that is increased, not to the same degree as some of the, such as plastin, but it's increased about 5-fold. That's over normal consistently, and we do see that there's a gradient. So this says that some of these genes, the expression can be detected in MF. And so there's a relationship between mycosis fungoides and Sézary syndrome. So what's the mechanism for upregulation of these genes? We looked at the promoter and we saw increased CPGs, and we thought, we focused on methylation because no other mechanism came to mind that could be, consistent, that would hit all these genes at once consistently in all these patients. So on the left is we looked at global DNA methylation. On the left here's normal, and here's Sézary syndrome patients. Here's a subset. And we see that there's significantly decreased DNA methylation. And if we look at a gene that we saw highly expressed, PLS3, here's the expression in normal. This gene is significantly hypomethylated in Sézary patients. And how does this, methylation control this gene? And is it actually involved in controlling this gene? And we were able to clone out the promoter of PLS3 into a reporter assay, methylate it, and show that we can suppress it. So these genes are regulated by methylation. And this is, the more the promoter, you're able to suppress it more aggressively. So what we found is that there's a association between methylation and Sézary syndrome. And what's the relationship between DNA methylation and cancer? Well, this change has been observed many years ago by Volkostein and Feinberg in colorectal cancer. Now, is there specific methylation changes in cancer? Most frequently, actually, hypomethylation has been observed in long interspersed nuclear elements, these line repeats or allele repeats. So in the past, it has not been shown to be very specific. No specific pattern of demethylation has been observed in cancer. The thought is that it may increase genomic instability. But in studying Sézary syndrome or an MF, we do see, we hypothesize that there is a specific pattern, and we're seeing it affecting certain genes. So that's something that's unusual. So we next ask, is there specific pattern of differential methylation that affects CTCL, MF, and Sézary. What we did here, so what we did here was to purify T cells, and then from Sézary syndrome, we perform DNA methylation from the same population of cells we did RNA-seq, so that we can correlate methylation and gene expression. And what you see here, we ran these on Illumina A50K methyl chips. And what we can see here is that the green is normal volunteers, and the yellow is Sézary syndrome. And we can see that actually we were able to identify these are the top 100 differential methylation sites in the chip. And we can see that there's actually some fair uniformity of methylation in normals. But I think I was surprised that we could see uniformity of methylation in patients. And so there's so that suggests that differential methylation can be specific in cancer, or at least in Sézary syndrome. And then since we did the RNA-seq, we could correlate expression in these individuals to methylation pattern. And what we found was that the Sézary syndrome had increase or loss of methylation for genes that are highly expressed compared to normal. Now, so that was an interesting finding, and so then that led us to ask, what about methylation in MF? We found Sézary syndrome. These are highly advanced tumor cells, and they have demethylation. Well, we then looked at patients with tumors because early disease, we can't purify cells that may have the same changes from the blood. So we were able to recruit patients with tumors, elute their cells out, and then purify them, and then looked at the methylation. And here's the methylation level of a certain number of sites for these genes. Here are the genes that we see that are highly expressed, and this shows a low methylation. Here's is DPP4, which is CD26. CD26 is lost in Sézary syndrome, and so that would be hypermethylated, and we see that. So that's consistent. And so what happens when we look at tumors? We see that there's it has a partial loss of methylation for the genes that are increased, and this is not the case in early disease, and we weren't able to get T cells sufficient amount for the study. We took peripheral blood here. We CD4 T cells there. And then we also compared to disease control psoriasis. So this is not seen in inflammatory disease, but this change is seen significantly in Sézary syndrome and in tumors. Now, what are other properties of these Sézary syndrome data that we can extract based on the methylation? And Bauer is Mike Bauer at UAMS. He was looking at the epigenetic clock, and so certain number of methylation sites correlate to chronologic aging. And so we also looked at, so here's a analysis of the BID, which is benign inflammatory disease. We grouped psoriasis and atopic together. And then we had other specimens that we ran on the A50K chip. Well, he was able to, show that actually Sézary syndrome T cells, based on the methylation, have accelerated aging. So this is not work that we published, but this was rather novel. So Sézary syndromes have accelerated, age over time compared to actually, psoriasis or other inflammatory disease. So it's very distinct, and we can see the eluded, T cells. They also show this accelerated aging. So that's part of, there's a mechanism that leads to aging, which I think it's unclear, but we see changes in the methylation pattern that's specific. Now, so how about other alterations, and how does the other populations of disease sort out based on methylation? Does atopic dermatitis or psoriasis, does that have any relationship to MF? Do they show partial change? And so this looks at the differential methylation between Sézary, the tumor-eluded T cells, and then we have normal, which is scattered about inflammatory disease, CD30. We had a subset of CD30 peripheral blood. And what we see is that actually, again, consistent with what we, with the aging, Sézary syndrome and the tumor-eluded T cells share a methylation signature that's very similar, and that's distinct from, that's different, and it's not seen in the benign inflammatory disease. So this signature may be valuable for separating, mimickers of CTCL from real CTCL, and that's important in treating. And this just shows the next step is, do we see it at the nucleotide level? And this, we were able to do targeted methylation sequencing. And here's up top is Sézary syndrome, and then below are normal, and then our atopic and psoriasis. And we can see that in sites where we can identify where we could do targeted methylation sequencing, we see that there's a significant difference between Sézary syndrome and normals. And this is DPP4 CD26. And that's, again, that's loss in Sézary syndrome. And we can see hypermethylation, and that's what you would expect. And this is a hypomethylated in normal, as well as, and we don't see changes in psoriasis or atopic dermatitis. So that suggests, so our findings suggest that MF and Sézary syndrome T cells have significant consistent epigenetic change that can give rise to altered gene expression and phenotype. And this mechanism will be important to understand pathogenesis and future treatment. Now, I'll finish up with a couple of more applications. So yes, we've done a lot of studies on gene expressions. Can we use that to help improve a diagnosis? So here's a, here's a disease that can mimic Sézary syndrome, okay? It's a disease called lymphocyte hypereosinophilic syndrome. And the parameters that patients have, such as is on the left, and they have very similar clinical finding, except that Sézary syndrome is malignant and lymphocyte LHAS, I'll use that for short, is benign, but they can have increased eosinophilia. It's enriched in CD4 T cells. So one of the fellows who I work with, she said, well, let's see if gene sets are able to differentiate these two conditions. And one of the benefits of having all these data sets submitted to the national database, the repositories, we could pull it out and we can use our data set, which we showed differences from previously, and then we could incorporate their data set, these were all run on the same microarray platform, so we were able to have our bioinformatics person batch correct, and then we were able to compare these two diseases and ask, do we have that have similar clinical findings, that have similar gene expression, but also do they have different gene expression that can be useful to help help diagnose these two different diseases. And on the right, we can see the normal CD4 and the normal memory have similar gene expression pattern. And here we have the LHAS subset, and then we have the Sézary syndrome. And we can see that there are genes that are different between LHAS and Sézary syndrome that may be helpful. And here we'll move ahead. And what are some of these genes? Well, the LHAS unique genes, we identify IL-17RB gene, but there's a lot of shared genes overlap, and GATA3 is one of them, and that's expected, and that's not surprising. And if we look at the level of expression of these genes, it's very consistent. GATA3 is high in both, in the black here, LHAS as Sézary, and then not in normal. And then if we look at gene unique to Sézary syndrome, tox, it's high in Sézary, but it's not high in the LHAS or normal. So we've identified genes that can be useful in help differentiating patients that have very, very similar clinical phenotype. And this just shows, actually, I met Dr. Rosati at a meeting, and she says, hey, we had this patient, we can't sort out whether he has LHAS or Sézary syndrome, and they were challenged. And we offered to run the gene profile. And so the red arrows mark the expression of this individual patient, and the gene profile seems to show that this patient does not have Sézary syndrome. We ran more than one gene, and we're confident. And this patient had increased IL-17RB, so they treated the patient with interferon, and I think that really helped the patient. And then in terms of, that was diagnosing, but can we use some of these genes to follow response to treatment? So I'm going to share our experience using mogamulizumab treating a Sézary syndrome patient. Mogamulizumab is an anti-CCR4 molecule that targets the CCR4 on the neoplastic T cells. And this has been shown to be more effective in patients with Sézary compared to MF. And here's an example of a patient with Sézary syndrome, and after the treatment, he responded. And we wanted to use the gene expression profile in a real world setting to see, can we use these genes to monitor, gain insight into response. And so we had 6 patients who had Sézary syndrome, who got treated with mogamulizumab, and then we got blood 2 times afterwards, and we measured the subset of genes, the Sézary syndrome genes, Th2 to see if the Th2 genes correlate with improve in symptoms, and Th1 genes, interferon gamma and STAT4. So this shows the gene expression changes after treatment of the Sézary patients with mogamulizumab. And we can see for the Sézary syndrome biomarker subset, the plastin goes down, they all go down, which is reassuring. Th2 genes decrease significantly, and then we see Th1 increase. So that suggests to us that these genes can be helpful in monitoring response. Also, there's the cytokine genes show that there's changes in the immune profile, and that's important in following patients long term. And interferon gamma increase shows that tumor immunity may be increased. So in summary, today what I did was just review the history of mycosis fungoides and Sézary syndrome, share that there were histologic and immunologic findings that now can be extended to gene expression. There's similarities, partly extreme. Some of these may be involved in the transition of, turning on these genes may be important in, let's say, for changes in the personality from Dr. Jekyll to Mr. Hyde to a point where these patients are more aggressive. Malignant T cells have altered gene expression. CTLA4 is a gene that's upregulated. It may be important in the indolent nature. It may suppress the tumor immunity and over time, and that may be one reason we see this disease extend over time. We identify novel genes. Exactly how that panel gets turned on is unclear, but they have a neurogenesis enrichment in terms of their pathways that are enriched. We found epigenetic abnormalities that are important. That's new, and it's associated with accelerated Horvath age. This epigenetic change is not seen in early MF or the benign inflammatory disease, and some of these may be used as a biomarker. So in terms of a pictorial schematic of how we can envision evolution of MF, the two sides, two faces of MF and Sézary syndrome, we see as patients progress, there's changes, loss of cytokine expression, increased immunosuppressing molecule. There's epigenetic changes that are driving this progression, and further studies of these will be important in understanding this disease. And with that, I review. I'd like to acknowledge the patients, the volunteers who really provide, the ability to do this work, and then the personnel, and then the support I've received. I can answer questions.